Good morning, everybody, and welcome back to Journal Club. Today, we'll be back on the coronary side of interventional cardiology, discussing the quite often scary phenomena, but one that nevertheless we should all be familiar with in cath lab, which is that of no-reflow phenomena. I'm delighted to welcome Vincenzo Vetrugno from Modena and great friend and colleague Carlo Tumscitz from Ferrara. Pleasure to have you both. Looking forward to the discussions. As ever, if you have any questions, please type them in the chat and we'll answer them at the end, or you can ask them live. And I'm sure Carlo will be happy to answer them. So just before we get started, today's poll was, when faced with no reflow phenomena during ACS, which is your usual pharmacological strategy? An overwhelming majority of people have gone for adenosine, 75%. A few people in the minority with verapamil, only one person with epinephrine, and the others with a mix of the above. So it seems that epinephrine, one of the topics of our conversation today, is not a popular choice. So let's see the discussion, and Vincenzo, over to you now.
Thank you very much. Good morning, everyone. My name is Vincenzo Vetrugno. I work in Modena University Hospital in Bajvara. I'd like to thank the GISA Young Board for inviting me to present this interesting paper, recently published in Circulation Cardiovascular Intervention, and which is entitled COAR trial, meaning comparison of intracoronary epinephrine and adenosine for no-reflow in normotensive patients with acute coronary syndrome. So, as you said before, I think this is an interesting topic because I think all of us, at least once in their clinical career, faced this tricky phenomenon, and it might have some catastrophic consequences in some cases. So, if we have some new strategies to overcome it, I think it's very welcome, isn't it? So, no-reflow is defined as a deficient perfusion of the myocardium despite restoration of the patency of the epicardial vessel, which is the culprit in the context of an ACS, but not only in the context of an ACS. Of course, after excluding the presence of other causes of impaired blood flow, just like dissection, residual stenosis, thrombus, or spasm. No-reflow is quite frequent. It can be prevalent up to 32%, according to literature, in patients with an acute coronary syndrome, but we may find it also in stable patients undergoing venous graft PCI or during rotational atherectomy. In literature, a number of therapies have been tried in order to overcome this phenomenon, mainly adenosine, verapamil, nitroprusside, or nicardipine. And some then showed some improvement, not only from an angiographic point of view, so in the coronary flow, but also in terms of better prognosis and follow-up. According to literature, adenosine and nitroprusside are the most widely used drugs at the moment in the treatment of no-reflow, but there are some mixed and debatable results. And in particular, as one of the major consequences of no-reflow is hypertension, where the use of strong vasodilators, just like nicardipine, verapamil, nitroprusside, or also adenosine, might be questionable. Well, in that scenario, the only useful option seems to be epinephrine nowadays, which has been used in, I should say, small and retrospective studies up to now for treating refractory no-reflow after PCI in the context of an ACS. But the data is lacking about a comparison between safety and efficacy with the widely used adenosine, especially in normotensive patients, because I told you that most physicians tend to use epinephrine when they do so just in hypertensive or bradycardic patients. So the aim of the study is to assess the safety and efficacy of intracoronary epinephrine in the management of no-reflow as compared to intracoronary adenosine in normotensive patients in ACS. So this was an open-label randomized control trial. The inclusion criteria is obvious. So no-reflow defined angiographically as an impaired TME flow, so TME flow grade less than 3, and the baseline systolic blood pressure more than 100, so not hypertensive patients. This is the study flow chart. As you can see, more than 2,000 patients were screened in the first place, and according to inclusion and exclusion criteria, the final population was of about 201 patients, recruited consecutively from December 2020 to May 2021. All of them had an ACS course, and they were randomly assigned to one of the two groups. So, as you can see on the left, epinephrine group or adenosine group. Epinephrine group received an amount of epinephrine, of intracoronary epinephrine, ranging from a total dose of 100 to 600 micrograms, as you can see, which were administered as consecutive boluses of 10 micrograms of epinephrine, according to a certain dilution 1:1000, which is thoroughly explained in the paper. While the adenosine group received a total amount of adenosine ranging from 60 to 1000 micrograms. And all these patients received intracoronary nitrates according to the operator's decision. And they also received GP inhibitors according to international guidelines, as the authors mentioned in the paper. So about outcomes. So there were some primary outcomes and secondary outcomes. Primary outcomes were angiographic, as you can see here. So post-administration TIMI3 flow grade. So restoration of a normal TIMI3 flow. Then final corrected TIMI count. As you may know, corrected TIMI count is the number of angiographic frames for the coronary artery to be filled by contrast dye from the beginning of the coronary artery to the very end of it, corrected for the length of the vessel. So it's a bit more precise as compared to TIMI flow grade as an angiographic index, because of course it's not a qualitative index, but it's a quantitative. While the third one was myocardial blush grade, which is probably the most the angiographic index, which is mostly correlated to myocardial perfusion. So of course it was taken into account as well. For the secondary outcomes instead, they were clinical, so all-cause mortality and the usual MACE, as you can say, so any kind of arrhythmias, recurrent MI, repeated vascularization, cerebrovascular accident, heart failure, and LV ejection fraction measured both at the time of discharge, so we're talking about in-hospital outcomes, as well as at follow-up, so 30 days after the procedure. So we can say a short, mid-term follow-up. Let's go straight to the results. This is just table 1 comparing the baseline demographic and clinical characteristics between the two groups, epinephrine and adenosine, just to show you that they were homogeneous population. As you can see, the systolic blood pressure was normal, about 100, as we mentioned before. There was no statistically significant difference between the two groups as for these clinical features, cardiovascular risk factors, and so on. So won't waste time here. Table 2 is comparing the angiographic and procedural characteristics between the two groups here. So as you can see, STEMI patients were the vast majority of the population, so more than 92% of them, which is, of course, the clinical context where No-Reflow is mostly found, unfortunately. There was not significant difference between the two groups as for the number of cyst vessels, as well as for the culprit lesion, the culprit vessel, and about the LV ejection fraction, patients were divided into 3 groups, roughly speaking. So less than 30%, 30 to 40%, and more than 40%. And again, there was not significant difference between the two groups as for the distribution within these 3 subsets. As for the angiographic, of course, none of the patients was TIMI3 flow, of course, and the use of GP inhibitors, as you can see, was of about 20% in both groups, with not significant difference between them. There was a slightly higher use of nitrates in the adenosine group, 88% as compared to 75%. But apart from this, there was no other significant difference. Let's go straight to the primary outcome. About the TIMI flow grade, as you can see here, there is a comparison of post-stenting, pre-administration versus post-administration of one of the 2 drugs, so epinephrine in the first and third column, and adenosine in the second and the fourth one. As you can see, there is a strong improvement of TIMI flow grade, passing from pre-administration to post-administration, with a final TIMI3 flow grade, which was one of the primary outcomes, of 90% in the epinephrine group as compared to the 78% in the adenosine group, with a difference which was statistically significant, as you can see. So we might argue that epinephrine might be slightly better in restoring a normal TIMI flow 3 grade in patients with No-Reflow, normotensive patients with No-Reflow in ACS. As for the other angiographic index, corrected epinephrine count, as you can see here, we always have epinephrine group, adenosine group, and in red we have the bars stating the pre-administration status, while the green ones are the post-administration ones. So as you can see, the median of corrected epinephrine count was slightly lower in epinephrine group as compared to the adenosine group, with a difference which was statistically significant. But if you consider the mean reduction of the corrected epinephrine count from the pre-administration to the post-administration in both groups, well, this reduction was not statistically different between the two groups. So we can say that as a whole, probably corrected epinephrine count did not differ that much between the two groups. As for the McAlder blush grade, which I said is probably the most important angiographic index, well, it didn't differ between the two groups. So 55% of the patients in the epinephrine group reached a normal McAlder blush grade at the end of the procedure, as compared to 45%. But anyway, even if epinephrine was not better than adenosine, at least it was not even worse. So it's good news anyway. Let's talk about the secondary outcomes now, but first we can say something. So most physicians are a bit frightened to use epinephrine in the context of a STEMI because there is fear of two things. So of raising blood pressure and of course in some life-threatening tachyarrhythmias. So, you know, ventricular tachycardia, ventricular fibrillation, maybe also atrial fibrillation, with a high rate, high ventricular rate, atrial fibrillation. Well, none of this were statistically different between the two groups. As you can see, a raised blood pressure more than 200 was found in just 4 patients in the epinephrine group, in all patients of adenosine, of course, but the difference was not significant, as well as atrial fibrillation, ventricular tachycardia, ventricular fibrillation. The only difference was found for sinus bradycardia, which was more prevalent, of course, in the adenosine group, but we already knew this, and sinus tachycardia, which was slightly more prevalent in the epinephrine group, but it was reported to be usually self-resolving and very well tolerated by the patient. So we must not be afraid of using epinephrine in this subset of patients. As for in-hospital outcomes, very good news here as well, as you can see, because mortality did not differ significantly between the two groups, as well as arrhythmia, reinfarction, repeat vascularization, cerebrovascular accident, heart failure, no difference at all. The same for the follow-up at 30 days. The only difference was found for LV ejection fraction, because as you can see here, the epinephrine group, more than 40% of the patients were allocated in the LV ejection fraction more than 40%, as compared to 22.9%. So we might, this might just suggest that epinephrine might help myocardium to restore just part of its pump function follow-up. So the authors conclude that epinephrine is safe and slightly more effective than adenosine in No-Reflow in normotensive ACS patients. However, overall in hospital and short-term outcomes are comparable. Epinephrine may be used as an alternative first-line drugs, especially when there is a fear of bradycardia or hypertension associated with adenosine in normotensive patients. The only limitations reported by the authors were, of course, the single-centered recruitment and the exclusion of patients who refused to participate in the study, which were actually just a few, just 15 or so. So I don't think that's a strong limitation at all. Thank you very much.
Okay, thank you, Vincenzo. Very nice presentation on this topic. Carlo, can I invite you please to give us your comments, both on this paper, but also in general from your experience in Cath Lab?
Thank you very much for your invitation. Thank Vincenzo for your comprehensive speech. It's very clear now, I think, for everybody. Probably everybody wants to know something about experience in this field, because everybody experienced the No-Reflow phenomenon. I could describe the No-Reflow as Nicoli in 2009 explained in an elegant paper in American College of Cardiology. And this was described as a complex condition due to several pathogenic components. It's just not a matter of distal embolization. There is also ischemia, a reperfusion, and maybe predisposing factors. And I think that each one can roll a key role, can play a key role sometimes, or conversely, sometimes all together may contribute differently to the adverse event. So actually, we are talking about probably a 7% rate if we make we try to understand how many patients we can have with this phenomenon. I think obviously, as in the paper described by Vincenzo, it's quite common in STEMI, less in other conditions, but you can have it also in stable patients sometimes. So it's something every interventionalist can face in his experience. One thing that we have to say first is that a significant proportion of these patients have this phenomenon disappear without doing anything. So we don't really know exactly when the pharmacological treatment is effective, because sometimes it's just a matter of 5 minutes. And in other cases, it's a dramatical scenario. So we have to treat them, but we don't know if it would be good even without the treatment. I think we should think about the therapeutic option, dividing these in two main groups: preventive strategy and drug used after No-Reflow as a COAR. And obviously, it's too late to think about preventive strategy when we have this phenomenon, because it's probably something we missed, or probably the phenomenon is stronger. Like, for example, talking about distal embolization for very big coronaries, where this effect could be even worse because of the volume of the plaque. Okay, I think this study highlights that there is another player in the field. So I think epinephrine, it's not maybe the best thing since sliced bread, but I think it's a very, very useful tool in the cath lab. So I think everybody should at least has its experience with this drug. Because after my participation in the RESTORE observational study by Navarrese, that probably something that appeared just a couple of years before. And I think that inspired this study because the administration dose was exactly the same. We started to treat all the No-Reflow phenomena with epinephrine. First of all, because of the study, but then I'm still using this drug very much in my experience. So I would like to give you some practical suggestions, because I understand that epinephrine just in this setting, it's something that interventionalists could fear for many reasons. As Vincenzo showed, even in the randomized trial, there was no adverse events more than in adenosine harm. So I think this is the first thing to say. But I think, first of all, everybody should have his dilution rate well written in this cath lab, just to have this prepared very quickly, because this is a situation where we don't have so much time to waste. So just to give an example, because I tried several dilution modalities, I think the last one that I'm using, it's very, very, very effective and convenient. It's just half of a vial, so half of a milligram. It's half a vial of adrenaline in 500 cc of liquid. So I think it's very easy, because 1 cc equals to 100 micrograms. So you can just dilute in just a couple of minutes, and then you will have you get aspirating something like a 10 cc syringe, where every cc is 100 micrograms. This is very practical and convenient, because as you can see in the paper, you should start with low dose. What's low dose? I think it's 100 micrograms, so just 1 cc, and see what's going on, because the patients are completely different from one from another, can have a very high response in rate and pressure and efficacy, and others needs to get up to a very higher dose. But I should say that this experience I I had the same with adenosine, because I think people normally use adenosine at a very low dose, but sometimes in these cases you should get up, even up to half of a vial. So as you can see in the study, they all we were treated up to 1 milligram of a dose, so a very high dose. Obviously, you cannot do it in any patient, so you should just use this ability to start from low dose and go high dose until you get at least some response. The response could be the absence of no-reflow phenomena, and that's the best situation you have, or you can have the side effects, and so you have to stop for that. For adenosine, obviously, is the AV block or the persistent bradycardia or asystolia. In adrenaline is high pressure, high frequency, high heart rate, so you have to stop for that. But at least I think you should get to this point because you needed the drug to be effective. In this patient, I think the tolerance is very high because the microcirculation is completely fucked up, if I can say this thing in cardiology. Obviously, when you start to use adrenaline, and so a new drug normally, I think you may start to use it even in different scenarios. For example, another setting where you can be very effective and very efficacy, there is a high efficacy, is when you have an acute contrast media anaphylaxis. It's a very bad situation. I think you can prepare it in 1 second and you can use it very quickly to stabilize the patient. So actually, I could summarize saying that you don't have any magic tool to make the bad thing disappear, but I think that it's the most effective drug that we have. And so I think everybody should learn how to use it and have his own experience. Probably we miss a lot of important data regarding the mechanism of this. It is quite difficult to have papers assessing IMR or other invasive assessment of the microcirculation. But I think that at least we have a lot to study in this field. And this is a good start because I think it's the best option that we have.
Okay, thank you. It's great to have such insight, especially for all the fellows who are connected. So let's take some questions now from the chat. So Pierre has a question about, would you consider epinephrine as your first choice to use?
You already answered to that. Thank you, Carlo, and nice presentation, Vincenzo. For the second question is more detailed about the CTO recanalization, slow flow, no-reflow in the CTO recanalization. That is a rare complication but associated with MI and ischemia. In your experience, what's the main cause of this phenomenon and how we can handle it? Thank you.
I participated to a nice paper from the Lara. I think this, if I can make some hypothesis about the no-reflow phenomenon in CTO setting, I think the most probable situation is when you have related to the myocardial muscle that we have under the CTO. Probably we have a high amount of no viability. In this case, we can open a big vessel with a very limited viability. This is obviously a lack of selection. I mean, you should be able to know it in advance. But when it happens, I think you have like a big river going to a very small village. And so the flow is very slow. So it's not exactly as a no-reflow phenomena. I think in this case, probably we bring up the wrong patient. So I think there is nothing to do. But in other cases, it's just a matter of, I think, rebalancing the flow because of the collateral vessels. So I think, for example, in this setting, just 1 cc or more of adrenaline could be just good, because there is something like a vagal effect, and the slow flow is just related to the situation. And I think in 5 to 10 minutes normally it's anyway getting better, so you don't really need anything. But if you want to be quicker, I think, for example, adrenaline could be a good option to solve it. And obviously,
also for like tachycardization, for the tachycardization of
yeah, obviously you have this effect, but if you go from a low dose, it's not a big deal. Normally, it's not the first effect. It's you can start to see a tachycardia when you're going a little bit higher in dose. So it's very easy to use. I don't think you're feeling, and also the effect is very short in time. So after a couple of minutes, there isn't anything back. So I think you can use it even as how can I say, aesthetic effect, because of the end of your procedure. You want to be sure that the flow is very good. So I think most of these cases is reversible in CTO setting, but sometimes you have this massive embolization. That's another completely another situation. Then you may have also a persistent no-reflow at the end of the procedure sometimes.
Thank you.
Okay, Marco, you had a question?
Yes, ciao Carlo and Vincenzo. Thank you for your presentation, very well done. So Carlo, when you decide to stent after no-reflow, do you base your decision on TIMI flow restoration? And second point, is there any rule, or do you feel that mechanical circulation support like Impella can help to the restoration of normal flow? I'm thinking about microcirculation dysfunction, so unloading the ventricle may help you to go out of the operating room with a better flow, and maybe also for stabilization of the patient.
Thank you, Marco, for your question. I think it's a very important point. First of all, we are talking about late presentation MI. That's the worst scenario in MI, where you often have a no-reflow and the ventricular dysfunction. As you probably remember, I'm keen to very early stenting, so I'm not preparing the lesion too much in STEMI, just to have less embolization possible. So most of the time I have this situation after stenting. But if I have still to decide if to place a stent in this situation, normally I do it if I have any doubt that that could improve the flow, because sometimes it's not possible to have a good flow without stenting. For example, balloon, it's not enough. Obviously, it could be worse, but just in doubt, I prefer to have the stent placed, so I don't have any doubt that you need something more in the procedural part of the procedure. So this is first said that normally I have the stent in place. Then another thing that I missed to say, I think it's very important, is if you have an aspiration cut, a thromboaspiration, if you can use it to deliver the drug more distal than you can, because you have this topic to have the effect exactly where you need it. This is very important because, for instance, you can use both drugs, so adenosine and epinephrine, or adenosine and nitrates, or nitrates and epinephrine, or all together. So the maximum effect you would like to have to maximize. And I'm pretty sure that in this case, helping the patient with ventricular devices like Impella could be of great help, because I think this phenomena is related to different scenarios. I think the slow flow can increase the thrombosis, and so everything you can do, it's useful. Obviously, we don't have a widespread availability of Impella in this case, but I think if you can, I think there is low ejection fraction. Obviously, I wouldn't use it for right coronary artery STEMI. But for LAD in late presentation, I think it could be a good option. We need data about that, but I'm pretty sure that at least it's very important for the rate of mortality that you have in this patient.
Okay, so we're at time, but there's a couple of really good questions. So we'll just quickly go through them if it's okay, and then finish soon. So Alessandro's asking about preventing no flow in the context of a high thrombotic load, thrombus aspiration with and without these pharmacology, or do you have a preference when to go with one and the other?
This is a very important point because we are still lacking a good way to aspirate the thrombus, I think. We are actually starting to enroll in a new trial where we are using a thrombus retrieval tool. I think it could be the future, and it could be much better than thrombus aspiration catheters. As you know, we have also mechanical aspiration as an option. I think in some cases where there is a huge amount of thrombus, this is the only way actually we have to solve the problem. Obviously, we should use 2B3A, but if it's a late presentation, sometimes it's not effective at all. So I think we need something mechanical. So I could say that I'm still using the manual aspiration tool, but I think it's effective in more than 20% of the cases I use it. So I think the future is thrombus retrieval because it's very, very effective and it's easy to use. So there is some paper published as a case report about this. I think when the thrombus is big, sometimes it's impossible to retrieve with manual catheters. And also, if the thrombus is has a big volume and probably is not so soft, if you use it, for example, mechanical aspiration, you may just move it down or up, and so you're not really doing what you need so to keep it out. Obviously, in the poor man land, I always try to stand early for that reason, to have at least the thrombus caged behind the stand very early, and not using a balloon to prepare the lesion so much in this setting. But as you know, the percentage of patients who experience no-reflow, it's very high when you have this kind of a high thrombus grade, like 3. For example.
Okay, thank you. You touched on this point about drug delivery, and I know also working with you, you tend to use sometimes aspiration catheter if you need, so you can also deliver. But with epinephrine specifically and practically, do you have a preference from guiding catheter, or do you try to get as distal as possible?
I think compared to adenosine, it's much easier and more convenient to use it from the guiding cat. Because epinephrine, I think, in this setting is easy to use because you have this effect gradually. Conversely, if you're using adenosine, I never use it the high dose from the guiding catheter. You always use anything like OTV balloon or whatever you want to use it. It's much better because the side effects are very early. So I think for adrenaline, you can start using from the guiding catheter. I think it's not a big difference.
Okay, and then the last question just to end. How might you explain the significant improvement in ejection fraction given that the angiographic results were more sort of overlapping or not concordant with that?
This is an interesting point because we may expect benefits in the ejection fraction if the flow is restored. But I admit that I have many doubts about this result. Even in the real life, I don't know if we have a good flow at the end. It's just a matter of aesthetics. So the procedure seems very good, but maybe the viability is completely lost anyway. Obviously, I think there is an effect in the early events. So if you have a good flow, I'm pretty sure that the early events are less because when the flow is so slow, sometimes you have thrombosis again. So you may experience many other adverse events. But considering the flow, I'm not still sure that having a good flow at the end of the procedure is so strictly related to the benefit, because probably most of the damage is already done. I don't think you're able to save completely the muscle after embolization. You will save the flow and probably you reduce the events, but I'm not pretty sure that it will go to this such of benefits.
Okay, great. So it seems like No-Reflow is a mystery, and the mystery continues, but we've now got a new drug to add to the mystery with epinephrine. So let's call it a day. We've just come to time. Vincenzo, thank you so much. Great presentation. Thank you for joining us in Journal Club. And Carlo, always a pleasure hearing you and your personal experiences. So thank you so much for joining us and sharing your insights.